Welcome. In this session, we are going to start our discussion on non-infectious posterior uveitis, and we'll find that non-infectious posterior uveitis consists of a large number of clinical entities, often difficult to differentiate one from another and having more or less similar findings on diagnostic examinations. Posterior uveitis is intraocular inflammation primarily involving the retina and or the choroid. However, the following posterior segment features are not considered when we define an intraocular inflammation as being posterior, such as macular edema, optic edema, peripheral retinal vasculitis, and retinal and or choroidal neovascularization. These may occur in anterior uveitis, posterior uveitis, intermediate uveitis as well as panuveitis, and does not define an intraocular inflammation as being posterior. Choroidal neovascularization arising from intraocular inflammation responds to anti-inflammatory therapy and may not require anti-VEGF therapy. An anti-VEGF therapy, which is the standard treatment for choroidal neovascularization associated with entities such as ARMD, myopia and so on, may not work in uveitis associated choroidal neovascularization if the intraocular inflammation is not adequately controlled simultaneously. So the first set of diseases which we have in posterior uveitis are the white dot syndromes, and as I have mentioned, their clinical features are often overlapping and the findings on the diagnostic examinations are more or less similar. So we have a large number of entities classified under white dot syndromes, and they are uncommon entities. Now these white dot syndromes are usually bilateral, except multifocal evanescent white dot syndrome and acute retinal pigment epitheliopathy, which are predominantly unilateral. Symptoms of photopsia and blurred vision are almost universal in these syndromes. So in a patient complaining of photopsia or flashes, white dot syndromes should be under the differential diagnosis. The color of the lesions in active and healed stages are more or less similar among the white dot syndromes, and the lesion appearance on diagnostic tests such as fundus fluorescent angiography, indocyanine green angiography, fundus autofluorescence and optical coherence tomography are more or less similar. And typically, indocyanine green angiography and fundus autofluorescence reveal more lesions than is visible clinically on examination, and they help in monitoring the course of the disease, whether the disease is progressing or resolving. We know that fluorescent angiography reveals abnormalities of retinal circulation, and most white dot syndromes show early phase hypofluorescence and late phase hyperfluorescence. Indocyanine green angiography reveals abnormalities of the choroidal circulation. Normally, fluorescence leaks through the choroidal blood vessels, but indocyanine green does not leak through the choroidal blood vessels. So, indocyanine green reveals abnormalities of the choroidal circulation, and most white dot syndromes show hypocyanescence in both the early and the late phases of the ICG angiogram. Fundus autofluorescence picks up autofluorescence from lipofuscin inside the RPE, and most white dot syndromes show early stage hyperautofluorescence and late stage hypoautofluorescence. So hyperautofluorescence occurs when the amount of lipofuscin in RPE increases, which usually happens in the active stage of the disease, and in the later stages of the disease when the RPE is destroyed, the lipofuscin is also absent, so there is late stage hypoautofluorescence. On OCT, most white dot syndromes show hyperreflectivity of RPE and inner choroid and disruption of the ellipsoid zone. The ellipsoid zone is the junction of the inner segment and the outer segment of the rods and the cones, and appears as a very thin line just anterior to the retinal pigment epithelium. But among the white dot syndrome, there are differences also, and the differences occur in the demographics of the particular disease, in the lesion size and distribution in the posterior segment in the retina and or the choroid, the associated vitreous and anterior chamber of inflammation, duration and course of the disease, rate of occurrence of complications, and prognosis. So there are some similarities among the white dot syndromes, and there are also differences between the white dot syndromes. So the first white dot syndrome we are going to discuss is acute posterior multifocal placoid pigment epitheliopathy, or APMPPE. APMPPE occurs in young adults and no sex predilection has been found. And the symptoms are a sudden unilateral onset followed by involvement of the other eye. Patients complain of a central or a paracentral scotoma, photopsias, and 50% have a preceding flu-like illness. And rarely it is associated with cerebral vasculitis, which can be potentially life-threatening. So APMPPE is characterized by flat, yellow-white, large lesions, almost 1 to 2 disc diameter in size at the level of the retinal pigment epithelium. They occur in the posterior pole, and these are discrete multiple lesions. Discrete meaning they are separate. Now as old lesions heal, new lesions occur over subsequent few weeks, and they resolve within 2 to 6 weeks with pigmentary changes. Lesions of APMPPE may be associated with mild vitritis. In fluorescent angiography, we will see early phase hypofluorescence to late phase hyperfluorescent staining of the active lesions, and in the later stages, when the lesions heal, we find transmission hyperfluorescence. OCT shows hyperreflectivity of the outer retina and RPE and disruption of the ellipsoid zone. There can be shallow intraretinal and subretinal fluid. So here we see shallow interretinal or subretinal fluid. Optical coherence tomographic angiography show patchy areas of choriocapillaris ischemia corresponding to the visible lesions. And on ICG, the lesions show early and late phase hypocyanescence in both the active and inactive stages of the disease. So in this talk, phase refers to the early and late phase of the angiogram study, and stage refers to the course of the disease. FAF shows early hyperautofluorescence followed by hypoautofluorescence with time. So here we see hypoautofluorescence on FAF, and the margins show hyperautofluorescence. In APMPPE, steroids are often administered, but their efficacy is uncertain. However, cerebral vasculitis, if it occurs, requires urgent neurology attention, and we should be mindful of this association. Visual prognosis of APMPPE is usually good and depends on whether the fovea is involved or not, and recurrences are usually uncommon. The next entity we are going to discuss is serpiginous choroidopathy, which was also previously known as GHPC or geographic helicoid peripapillary chorioretinopathy. It can occur anywhere between 2 to 7 decades, and it also has no sex predilection. Symptoms are usually unilateral when the lesions start involving the fovea, but lesions can be detected in the other eye also, and the patient complains of blurred vision and paracentral scotomas. The lesions of serpiginous choroiditis are usually grey-white in color and extend in a geographic manner either from the optic disc region or from the macular area. So we find lesions extending outwards from the center towards the mid-periphery. Upon healing, the lesions may appear atrophic, scarred or pigmented, and new active lesions usually occur in the margin of the scars of the older lesions, and they extend the involvement of the posterior segment. Serpiginous choroiditis usually has mild or no vitritis, and choroidal neovascularization usually occurs at the border of an old scar. On fluorescent angiography, active lesions show hypofluorescence in the early phase and hyperfluorescent staining in the late phase. So we find hypofluorescence in the early phase and hyperfluorescent staining in the late phase. However, if there is a choroidal neovascularization, we will see hyperfluorescence in the early phase also. Inactive lesions show patchy, blocked and transmission hyperfluorescence depending upon atrophy and pigmentation of the healed areas. On optical coherence tomography, active lesions show hyperreflectivity of the outer retina and choroidal thickening, and healed lesions show outer retinal atrophy. On OCTA, we find choriocapillaris ischemia at the site of the visible lesions. On ICG, we find hypocyanescence of both active and inactive lesions in both the early and the late phases. However, if there is a choroidal neovascularization, it will show up hypercyanescence. Fundus autofluorescence show hyperautofluorescence of active lesions and hypoautofluorescence of inactive lesions. Tubercular choroiditis may have a similar appearance as serpiginous choroiditis, but it is usually unilateral, and it affects the posterior pole early and the area around optic disc later. Peripheral retinal involvement is also more likely as compared to serpiginous choroiditis, and tuberculous choroiditis appears and progresses in a multifocal pattern rather than expanding centrifugally like serpiginous choroiditis. In tubercular choroiditis, fundus autofluorescence shows lesions to be less homogeneous and more stippled. Purified protein derivative test and interferon gamma release assay are usually positive, but chest X-ray is usually negative. There is more prominent cellular reaction in the vitreous cavity in tubercular choroiditis compared to serpiginous choroiditis, and it responds to long-term anti-tubercular therapy, although steroids are also required to control the inflammatory aspect of the disease. Less commonly, herpetic and syphilitic choroiditis can also mimic serpiginous choroiditis. For serpiginous choroiditis, steroids and immunomodulatory therapy is recommended, and serpiginous choroiditis is usually a recurrent disease unlike APMPPE with progressive centrifugal extension. It is usually bilateral but can be markedly asymmetric, and the prognosis is guarded. 40% of patients have a final visual acuity of 6/60 or less. Now we have an entity called Ampiginous choroiditis. The name Ampiginous deriving both from serpiginous as well as APMPPE, and it is also called recurrent placoid chorioretinitis, and it can occur between 2nd to 7th decade and also has no sex predilection. It is also a bilateral disease with the patient complaining of floaters, photopsia and blurred vision. Individual lesions are similar to serpiginous choroiditis and APMPPE. However, lesions are discrete like APMPPE and not contiguous like a centrifugally expanding serpiginous choroiditis. Unlike APMPPE and serpiginous choroiditis, Ampiginous lesions are numerous. More than 50 in number is characteristic, so we find multiple lesions all over the fundus, and it can also affect mid and far periphery before affecting the macula. Serpiginous and APMPPE lesions affect the posterior pole early and usually do not extend beyond the mid-peripheral retina. Anterior chamber and vitreous inflammation is variable in Ampiginous choroiditis. Diagnostic imaging results are similar to serpiginous choroiditis and APMPPE, and on fundus autofluorescence, early lesions show a central hypoautofluorescence surrounded by a thin rim of hyperautofluorescence surrounded by another faint zone of hyperautofluorescence, and this is said to be a characteristic of Ampiginous choroiditis. Ampiginous choroiditis has a more prolonged course than APMPPE, and it can be up to 2 years, but the long-term prognosis is usually good even if macula is affected acutely. However, tuberculosis must be ruled out. Persistent placoid maculopathy is another white dot syndrome entity occurring between 2nd and 7th decades, which has a bilateral onset with the patient complaining of central visual loss and photopsias. And we find a well-delineated jigsaw patterned whitish plaque-like lesion in the fovea not contiguous with the disc, which persists for months, and satellite lesions may also be present. I could not find a non-copyrighted image, so please look up on the internet for a fundus photograph of this entity. And in persistent placoid maculopathy, visual acuity is said to improve upon resolution of the lesion if choroidal neovascularization does not develop, and choroidal neovascularization occurs more frequently in persistent placoid maculopathy than in serpiginous choroiditis. Multifocal choroiditis and panuveitis is another white dot syndrome entity, and it typically occurs in young myopic females. And there are 3 white dot syndrome entities which are more common in young myopic females: multifocal choroiditis, punctate inner choroiditis, and subretinal fibrosis. And patients with MCP also complain of photopsia, floaters, and blurred vision. Now we must note that although it's called panuveitis, it is classified under non-infectious posterior uveitis. It is a bilateral entity but can be asymmetric, and anterior chamber and vitreous inflammatory cells and haze is uniformly present. And this distinguishes MCP from OHS, that is ocular histoplasmosis syndrome, which we will be discussing in infectious posterior uveitis, and in punctate inner choroiditis, which we will be discussing subsequently. The lesions of MCP are often peripapillary and peripheral in distribution and is more often found in the nasal quadrant. So lesions in the nasal quadrant are typical of multifocal choroiditis, and the lesions are often arranged along curvilinear lines called Schlegel lines. Active lesions are creamy in color and have blurred edges, and hill lesions are yellow-white in color, appear punched out with variable pigmentation similar to ocular histoplasmosis syndrome, and between these healed punched out lesions there can be bridging fibrosis. There may also be peripapillary RPE disruption with fibrosis. In early phase of fundus fluorescent angiography, active lesions show hypofluorescence and late phase hyperfluorescent staining. Inactive lesions show transmission hyperfluorescence. However, CNV shows early phase hyperfluorescence. On ICG, we find hypocyanescence in early and late phases for both active and inactive lesions, but if CNV occurs, there will be hypercyanescence. On fundus autofluorescence, we find hyperautofluorescence for active lesions and hypoautofluorescence for inactive lesions. On optical coherence tomography, active lesions of MCP show sub-RPE drusen-like elevation with disruption of overlying outer retina, and it can also reveal macular edema and choroidal neovascularization. On visual field testing, MCP typically demonstrates an enlarged blind spot, and on electrophysiology, ERG may be mildly to severely diminished, but EOG is normal. Steroids and IMT are effective in controlling multifocal choroiditis and panuveitis, and anti-inflammatory therapy can cause resolution of the CNV arising from inflammation, and prognosis of MCP is said to be guarded. Cataract, macular edema and choroidal neovascularization can occur with multifocal choroiditis and panuveitis, and sarcoidosis, tuberculosis and syphilis need to be ruled out. Punctate inner choroiditis also occurs in young myopic females, as we have mentioned, and the symptoms include blurred vision, metamorphopsia, paracentral scotoma and photopsia. It is also a bilateral entity but may be asymmetric, and vitritis is absent in punctate inner choroiditis. Lesions of peak are small and creamy in appearance when active, and they are located within the macula and do not extend to the periphery. Inactive lesions appear yellowish white and punched out with a halo of pigmentation. Choroidal neovascularization can occur in punctate inner choroiditis. On fluorescent angiography, active lesions show early phase hypofluorescence and late phase hyperfluorescent staining. So we find hyperfluorescent staining in the late phase. And hill lesions show transmission hyperfluorescence. If CNV occurs, we will find early phase hyperfluorescence. On indocyanine green angiography, active and inactive lesions show hypocyanescence in both early and late phases. If CNV occurs, then we will find early phase hypercyanescence, and on fundus autofluorescence, active lesions show hyperautofluorescence and inactive lesions show hypoautofluorescence. On OCT, we find sub-RPE elevations, as we had seen in MCP, and treatment includes steroids and immunomodulatory therapy. Prognosis is good if choroidal neovascularization does not develop. Subretinal fibrosis and uveitis syndrome, also called SFU, also tends to occur in young myopic females, as we have mentioned, and symptoms of SFU include blurred vision, photopsia and floaters. Anterior chamber and vitreous inflammation is always present in SFU. Active lesions of SFU appear yellowish white and are located from posterior pole to the mid-periphery. These lesions may either resolve and disappear, may resolve and become atrophic, or may enlarge and coalesce into stellate white zones of subretinal fibrosis. I could not find a non-copyrighted image of subretinal fibrosis and uveitis on the internet, so please look up for an image on the net. Complications of SFU include macular edema and choroidal neovascularization, and the prognosis of SFU is guarded. Active lesions of SFU show early phase hypofluorescence on fundus fluorescent angiography and late phase hyperfluorescent staining. Treatment includes steroids and immunomodulatory therapy for subretinal fibrosis and panuveitis. We will be discussing the remaining entities in the next session. Thank you.